So the core thing that was the source of enormous Sturm und Drang was whether physicians would be paid for having a conversation about patients' end-of-life needs. And the truth of the matter is, I think that was a bit of a red herring. On the one hand, there is no question that the time for these discussions, these are longer discussions, where you're talking frequently with someone who is with a terminal illness, like a cancer or a congestive heart failure, or a conglomeration of lots of illnesses, and they're at that decline phase in their life. And getting a conversation underway about what people's goals are when it's no longer about just prolonging your life because we no longer can, what people's fears are, and then how to meet the needs that they have and find the right balance between imposing suffering on them and trying to extend their life as much as possible. Those conversations are hard, and one barrier, it's a small barrier, is the fact that there are not payments for being able to have those conversations. And that's one of the many excuses or barriers that prevent good conversations from happening. The fact that the administration has allowed these conversations to have some supplemental payments if they're included in your annual physical exam does not mean the problem is fixed. What is fascinating is that the whole death panel reduction and reaction to it has had for a period of time just shut down our ability to even have a national discussion about how to have the right kind of conversation. And in medicine, I wrote about the story of a 35-year-old patient of mine with terminal cancer. She had a lung cancer diagnosed in her 8th month of pregnancy. And it wasn't payment that was holding me back. Right to the end, we never discussed the fact that she was dying. And that was professional failure on my part, the desire that Sarah had and her family, who were just desperate for what the next experimental therapy would be. But in the end, we failed the family. And what we found is there are really good ways to run these discussions that I simply didn't understand, that palliative care specialists do understand, and taught me a little bit. And this is not a discussion about, do you want that experimental therapy or not? The discussion is, do you really know what your prognosis is? If you're going to get sicker, what are your fears? What are your goals? And with the remaining time you have, how much suffering you're willing to go through to try to extend that time just a little bit versus not. And I think those kinds of conversations are starting to permeate the profession to understand how to deliver on them. We have a long way to go to be able to bring ordinary doctors like me to understand how to do them well and to make it possible.